Let's talk about the pediatric emergencies. Most emergencies are preventable. So we have a lot of public education programs for helmets, making sure that there's nothing around the house that the child can drown in, and then using safety seats and restraints while they're operating or while they're riding in a vehicle. Let's see, we'll start off with medical emergencies for pediatrics. Usually start with the same as adults. Respiratory illnesses or medical emergencies such as diabetes are common in pediatrics. What we end up seeing though is our more common calls are to something like a toxin overdose or poisoning, because children can get into different pill bottles or fluids or containers or household cleaners. This is a preventable event, and we usually try to lock the containers up, and there's child safety proof locking for cabinetry, doors, and pill bottles and the like. Infections. Some common childhood infections will be the earache or otitis media, as well as upper respiratory infection, and the common cold or flu virus. Now the flu is a little longer than the common cold, but these all start in the upper airway and then may travel down into the pulmonary circuit. Again, these are preventable sometimes with our immunization series that all pediatrics should get, so make sure you maintain the questioning in regards to the immunization and immunization status. As far as trauma goes, trauma is two types of trauma. One is accidental, which we should be preventing. The other is with intent. These could be a family member, caregiver, or somebody else, and even accidental trauma. But take a look at the scene, the situation. This will take some situational awareness on the EMT or EMS provider's part to kind of read into the scene to determine whether this trauma was done with intent to harm or hurt. In that case, we'd also look for some types of head injuries, raccoon eyes, or battle signs behind the ear. As we work on the pediatric patient, a lot of times it's the airway that becomes problematic and causes then the child to have difficulty in breathing or dyspnea, and as a result of the hypoxia, a heart rate becomes slow and bradycardic. Usually the pediatric patient has a very strong myocardium or heart, and so we look at that type of emergencies being way down on our possible etiologies or differentials. So as we talk about airways, a lot of times the child has a large head with occiput region, and the shoulder blades causes the head to be more flexed forward, and in order to get the airway open, we would use the head tilt chin lift. But to help us maintain that, we may use some type of padding that goes underneath the shoulder blades of the child. This keeps the airway open. We then would find and identify the proper size or pharyngeal airway or a nasal trumpet or nasopharyngeal airway to then keep the airway open. Now as we go ahead and assess and take care of this patient, we also use something that's called a length-based tape. We would start off at the head, run this down to the feet. We'd find the color code markings, and this would help us to identify what types of medications, airways, IV fluids that we would use. We're still going to do our same assessment for airway, breathing, circulation. We're going to treat our life threats. We're still going to continue on with a sample history and OPQRST. We are also going to identify from the head to toe or focus exam what other things we can find. As far as treatment goes, there are treatment-specific things. This is a Buretrol for volume, specific amount that we would connect to an IV bag so that we don't overfluid our patients or overvolume the patients. Pediatric patients are going to require smaller size IV access. These are probably less than a 20 gauge, and we're looking at whatever site that we can find, but commonly we'll see it on the dorsum of the hand or on the foot. Once we, in the hospital, may even use something like a butterfly needle. If we're unable to, and in certain programs they have what's called an intraosseous protocol. If you're unable to initiate an IV in 2 attempts in less than 2 minutes, then you're able to go ahead and start intraosseous. We also have, this is intraosseous Jamshedi. We also have the bone, Easy IO bone drill in our protocols. This is usually an advanced skill, but just to keep in mind that this is something that goes into the bone, somewhere in the proximal tibial surface, and that we can enter fluids and medications through that route. Now lastly, as we take our assessments and our history, we need to make sure that we identify the caregiver and understand that caregivers nowadays are very versed in understanding the patient's medical conditions, and so we might use them as the primary source of all the information. So remember that the caregiver is a wealth of information as we address the pediatric patient.